whole team, we're very excited to be here. And this is actually, believe it or not, only a fraction of our team. So the team consists of probably at least twice the people that are represented. And we have a really, really strong cleft team here. And I'm really proud to be a part of it. I've been part of cleft teams at the Children's Hospital in Dallas, Texas, also in Louisiana, and we really have this core of incredible individuals who are very giving, very knowledgeable, that work right here in El Paso. We are ACPA certified, which is very cool. That's the national certification for a team. And then we also have the craniofacial component of our team, which is housed in the Children's Hospital. And pretty much it's the same members of the team at each locations. So the panel discussion, I hope y'all stick around for my lecture. It's going to be awesome. But the panel discussion is going to be good because I feel like there's a lot of confusion about just the whole team dynamic, how it works. How does it work when you refer a kid to us? And why do we even need a team? You know, there's a lot of surgeons out there who just go it alone and they just operate. But there is tremendous value to a team. So for the purposes of this panel discussion, I just wanted to put up a few cases. And I should probably introduce everyone. In the absent chair is my partner, that's Dr. Vernon Burke. He will be here. He's an oral maxillofacial surgeon. He's extremely capable. He's been on the cleft team here for 5-6 years now. And he does a lot of craniofacial secondary cleft surgery. Next to him is Dr. Liz Holge. And she is a pediatric dentist who does so much for our kids here. I'm going to brag about her because I can. So she does something called nasoalveolar molding, which really makes for our cleft kids. It takes a premaxilla, and you'll see one later in the presentation. It takes the portion of the cleft out here and can really mold that in and mold the nose. It makes a huge difference in these kids' final outcomes and in their surgical outcomes and their overall looks and appearances. She is the only provider of this service within about 10 hours in every direction. So she has people referred from, doctors refer to her from Dallas, from Albuquerque, from everything to do this service. So it's really amazing. She's also on call at the Children's Hospital. Andrea Sweetnam is our team audiologist. She is pivotal to all of these kids' lives in that she is providing the testing and the knowledge of whether or not these kids can hear. What do they need to be able to hear? What are the next steps in ensuring that we get these kids the ability to hear and be productive members of society and just be, interactive members in a school setting or wherever. And then we have Marlene Munoz. Marlene is our craniofacial coordinator for the Children's Hospital Clinic. She was a NICU nurse, then a PICU nurse, and she's now our craniofacial coordinator, which is a huge deal to have those skills that she brings to our team. Because being the coordinator, you have to know Dr. Burke. Please a round of applause for Dr. Burke. I've already introduced you. I said wonderful things. So Marlene is the craniofacial coordinator, and this really is a vital service because it's so much more than just coordinating like here or there. It's like the social aspect of the families. It's knowing these families. It's becoming intimately, involved with their lives, and she's the person that they call to get the services they need. And then we've got Lauren, and Lauren is a dietitian or a nutritionist. Dietitian. Okay, good. But she provides a vital service for these kids, and you'll see a lot of our kids are malnourished. A lot of our kids have feeding issues. A lot of our kids, this is why we need a team, because I'm the surgeon. I see something, and I'm like, oh yeah, we should fix that, and then they're like, well, the child's severely underweight and malnourished, and maybe we should wait, so you really need these services. And then we have Marianne, and Marianne is our speech pathologist. And of course, as you can imagine with the cleft kids, but also the cranio kids, they don't only provide a lot of help with the feeding in the initial, months of the baby's life, but they also provide a vital service with evaluating speech and all that's involved there. So for this panel discussion, I'm going to try, not to talk too much, and I'm really going to turn it over to our panel. So I'm going to we're just going to go down the panel, and I'm going to pretend like these kids just walked into our team clinic, okay? And I'm going to basically have them just make their observations, and let's see what everyone is looking at from their perspective when they see a kid like this, okay? So if y'all could take maybe 1 to 1.5 minutes per kid. So, okay. And I will say a little bit about a couple of these. These are the pre-op pictures for a kid that was recently treated at Children's Hospital. And I'm not going to say anything about his condition, but he walked in. He was actually flown to us from Palestine. There's no craniofacial surgeons in Palestine. And he needed services. So I will turn the floor over to Dr. Burke. When you walk in and see this kid, what are the things that are concerning to you? What kind of studies are you wanting? And what questions do you have?
So this young man is very complex. This is about as complex as a craniofacial case gets. He's got hypertelorism. His eyes are too far apart. You want to make sure that his vision is good in both eyes, or what his vision is like in each eye. You want to know what's underneath there, so you definitely need some studies to see what's happening there. Obviously, an assessment of how his nasal airway is doing, his sleep status. So you can see that his lower jaw is small, his upper jaw is constricted, so there may be some other airway issues there, and obviously some feeding issues. See what's going on with his temporomandibular joints. Really quite a bit, just initially, just kind of hit some big stuff.
Yeah. And I will go ahead and add to that, since I have the benefit of knowing the scans. We did do a CT scan. He's got unilateral coronal synostosis, so part of his skull fused too early, okay? He also has this bifid nose, and he has basically hypertelorism, as Dr. Burke was saying. His eye is far out. He's also blind in that left eye, which was congenital. And that left eye is actually a prosthesis. So Dr. Holguin, when you take a look at this, what are your concerns? What are you worried about?
Well, first of all, we really want to start with a full dental evaluation. We need to make sure that this kid is ready and is prepared for these major surgeries that he's going to have. We need to do his dental assessment, make sure he doesn't have gross decay, large areas of decay that can put in risk any bone grafts, any surgeries that they are going to do. As you can see, he has a lot of staining, he has a lot of areas of decay. You can see that his front tooth had some trauma. Children that have large dental protrusion, they are in risk of trauma. So whenever you see them that their teeth come to the room first than their body, you know that you need to kind of give us a referral, send them over so we can start fixing those things. The other thing is that every craniofacial surgeon will need a good orthodontic evaluation prior to any of these surgeries. Why? Because you need to have a good segment. If you know that this kid has that premaxilla way out there, very protrusive, well, they want to have a good anchorage when they are going to start cutting into bone and setting everything back. So that's one of the other evaluations that we will be doing.
When this young man came in, we weren't sure how much English he spoke because he was from out of the country. And so we started asking questions to the family that he's staying with. They were concerned about hearing because he wasn't turning and responding. We did a full hearing test, and it turned out the same side, the left side that had the vision issues, also was completely deaf. If he was here in the United States, we would look at doing possible Baja surgery, which could they put in a titanium pin into the left side using the right side ear, the cochlea to hear, we could do that if we knew he was going to be here. Knowing that he was going back to a place where he wouldn't get further care and he wouldn't be able to get programming and to get that taken care of, we opted to focus on the good ear and try to keep that ear healthy.
I think as far as coordination, this little one, we had to focus a lot on all of the social aspects as far as what his physical aspect, we need to provide social services. Of course, financial was one of the big ones. How are we going to be able to provide all of this care? The second thing was focusing on making sure that we were able to put him in all of the actual appointments, follow-up appointments, and care that he needed, as well as just, like I said, providing that social support, making sure that he was enrolled in school while he was here, or while he is here. Enrolled in school, providing any support, because of course he's coming from a new place, coming into here, and a lot of it, of course, is having that interaction with other students.
And then from a nutrition standpoint, as Dr. Yates mentioned, before these kiddos go into surgery, we want to make sure they're well nourished so they can heal and have better outcomes from surgery. So this guy, we first obviously take his height, take his weight, make sure he weighs enough for how tall he is, so we all know the term BMI. So check that, plot him on the growth charts, make sure he's within that healthy range. And then from there, either intervene if he's under the charts and malnourished in various ways, or if he's within normal range, maybe ask about his current diet. So he might be plotting normal on the charts, but his diet may be very minimal, especially because of, if you look at his mouth, I mean, he might not be able to masticate very well. So is he limited to pureed foods? Is he just taking liquid foods? Does he avoid whole food groups altogether? So doing that full nutrition assessment and making sure he is getting all of those micronutrients and macronutrients that he needs.
So as a speech language pathologist, I would be concerned about his speech and language both. Articulation is probably going to be impacted by the occlusions and the malocclusions in his mouth. He came here, he's not an English speaker, so, but I would expect that he would have some delays because of his hearing and vision loss. So I would want to do a complete evaluation and just kind of see where he is and get him into some kind of therapy for speech, maybe auditory verbal therapy if he's going to go with the cochlear implants, and just monitor also his feeding as well. Like she said, he may not be able to chew and eat. So those are some of the things that I would be concerned with.
So, thank you. So, this kid, he's a great story, really. So, his family was not allowed to come with him because they're in that kind of key time of life when they could be seen as terrorists. So, they were not allowed to pass through Israel. So, he's 11 years old. He came over on his own, and he's been staying with his family basically for about 4 months now. There was a local orthodontist who donated care. We were able to get his surgeries done. We came up with a problem list. So this is a problem list, and I'm sure there are more problems than I'm listing. However, so you can see the unilateral coronal synostosis. The concern for this is it can cause an increased pressure on the brain. So we sent him to the ophthalmologist to check out, see if he had, there's one associated with our team, see if he had any increase in intracranial pressure. He didn't. I sent him to our neurosurgeon, Dr. Trier. Dr. Trier also didn't see any reason for us to do anything at this point. And cosmetically, it wasn't that bad. So we decided not to operate on his skull. Also, his eye is far to the left. Well, it's unfortunate. There are procedures we can do to move that eye, which, little teaser for my talk, I have one that I show. Closer, but the problem is it's a huge procedure. We have one shot at this kid in the OR, and then he has to go back to Palestine. So is that really what we want to do? So then his biggest complaints were his teeth and his nose. Okay? So anyway, those were the things we kind of focused on. So Dr. Holguin donated her services, took him to the OR, cleaned him up from a dental perspective, and there was a lot of work. I wish I had the post Dr. Holguin shot because he looked way better after this. And then we took him to the OR, Dr. Burke and I, and we did the jaw surgery. We cut his jaw into 3 pieces. The upper jaw, we moved it back. And then he also had this cyst basically in his nose that obliterated his septum. And he had a lot of nasal issues before this. You could squeeze this lovely substance out of that right there. So anyway, so we removed this cyst, and then this is him just before and after on the table after we did his jaw surgery as well as his rhinoplasty. And then to show you kind of what kind of team approach this takes, I listed this just from memory, but these were everyone that I could remember that was associated with this kid's care in the last 2 weeks. And that's a lot of people. And it's a lot of people who know a lot of things, you know. So I'm very thankful that we have these resources here in El Paso, you know. And really a lot of people donated their time and services to help this kid. And he's about 1 week post-op, or 2 weeks now. I just saw him in my office today. He's doing great. He participated in Liz was able to get him hooked up into a Montessori, and they donated basically school for him while he's here. So he had a presentation where he was participating on stage with all the other kids today. So he's done great. Can I
say something?
Oh yeah, of course.
And ultimately, this is the payoff of every team in the country. We want this for every single of our kids. We want social acceptance. We want them to be part of something big. We want them to have a future. So all the things that we do as surgeons, dentists, therapists, all of the things that we do are aimed to this. We want them to be accepted, well cared, and loved.
We're about to wrap up on Malik. Is there anything else anyone would like to say? No, that was great. That's great. I'm like tearing up over here. Is there anything else anyone would like to say from the team about Malik? No? Okay. Our next case is more of our bread and butter. It's what we see all the time. And it's a kid with a cleft lip and palate. And we're going to talk about this a little bit more later on too, but cleft lip and palate is more common in Hispanics than a lot of other racial groups. So we do see a lot of it here in El Paso. So I'm going to turn this directly over to Dr. Burke. What are when a kid like this walks into our team, what are the first things that stick out? What are you worried about? What are you thinking about surgically? And go.
You know, as you guys may or may not have ascertained so far, I'm kind of a bone surgeon, and Dr. Yates does a lot of this, the primary lip and palate issues along with Dr. Bright. If I am consulted on a kid like this, a lot of my concern is to make sure that they're tapped into a surgeon who's going to eventually close the lip, but mainly that feeding is under control, that somebody's really looking at that and working with the mom and the care team to get that done, and that nasoalveolar molding is initiated early so that it can be most successful, which kind of is an easy segue to Dr.
Well, hopefully the first time I see the baby is not right there. Hopefully the first time that I get to see this family is when this baby is still in the womb. Okay, we want to make sure that we do a prenatal consultation. This is very crucial when dealing with unilateral or bilateral cleft lip and palate. We need to have a plan. We need to make sure that this mom is going to deliver this baby where all the other services that need to be initiated within the first couple of weeks of life are available. Okay, so ideally, I would like to sit with the family on a prenatal consultation and say, okay, mom, dad, your baby, he is going to be successful, he's going to be beautiful, he's going to need lots of hugs and kisses like any other baby. So this is what we need to start working on it. We will refer them over to speech so we can address the feeding issues. But within the first days of life, as soon as the baby is born, I need to be called into the hospital, okay? I usually say, when you are in labor, I don't want you to call your neighbor, your mom, your aunt, your uncle, anybody. I need you to call me first. Why? Because I need to know when the baby's born. Within that first 24 hours of life, we want to make sure that we assess every single issue and that we evaluate the cleft so we can have the initial impression for the nasoalveolar molding. And this impression needs to be done at the hospital. We do it in the operating room, not necessary putting the kid to sleep. 99% of the times we just go to the operating room to have an area where we feel safe and where we know that if there is any complications, we're in the best place that we can be. So we will make an impression. It's a regular impression for those of you who have had braces. It's like when you go to the orthodontics and they get an impression of your teeth. That's what we do. We take an impression. That impression goes to the lab. It takes about 5 to 10 days for the appliance to be fabricated. Once the baby gets that impression from the hospital, they can be discharged. Okay, once they are discharged, I'll see them in my office the following week, so we can start with the nasoalveolar molding therapy.
Also, yeah, I can't stress enough the importance of the prenatal consult. This baby actually came this week, and they had been seen, of course, and this was caught on ultrasound, but they were never sent to us. But it's much more of a shock to the parents, and they don't know what to do. But when they come for the prenatal consults to our offices, they get my cell phone number. I give them bottles. We give them bottles. We give them teddy bears. What more could you want? And we tell them to call us immediately. And that way, right when they're born, we can help them with feeding. And then a lot of it is just comfort and knowledge that the baby's going to be okay. And cleft lip's not a big deal, Do you want to talk? Okay.
Many times when they come for the prenatal consultation to my office, they see a family sitting in the reception area next to them that have a baby that it's 5 weeks into therapy, 10 weeks into therapy. They see the 1-year-old running around there that just finished their palate surgery. So that means a lot to the families. It does. So usually, they're telling me to tell you a little bit about the nasoalveolar molding therapy. Nasoalveolar molding therapy, it's a non-surgical protocol that we use prior to lip closure. Okay, so this needs to be done within the first 10 to 20 weeks of life. Unilateral cleft lip and palate, I can probably have it mostly corrected within the first 15 weeks. Bilateral cleft lip and palate, usually it takes about 20 to 25 weeks. And that means that I see them in my office every Monday for an adjustment, okay? Just like when you have braces, you go to the orthodontics every Monday so they can adjust your braces and make things get together and all of that. That's what we do with the nasoalveolar molding. This is Lily. I usually go everywhere with her. This shows very easy, not only to you, but also to the families. How is an nasoalveolar molding appliance? They get to touch it prior to them having one. They get to move it, play around with it, and it helps them understand. And this is how I explain them how to tape, how to move the appliance, how to take it in and out of the mouth, and all of those things. So I'm going to pass Lily around. Don't take her home, okay?
Yeah, why don't you talk about it?
Okay, yes. So we can see, do you want to go back?
Yes.
So this is the initial picture. As you can see, the premaxilla in this over here is totally out of the mouth. You can imagine that if we send that patient to the best surgeon, which is probably Dr. Yates in the country, he's probably going to do a very good job, but there's no way you can get that premaxilla into the proper position without having nasoalveolar molding. So one of the objectives that we want with the nasoalveolar molding is get that premaxilla as much inside of the mouth as possible. The other problem that we have here is that you can see the nose. The lip, the upper lip, is totally attached to the base of the nose, what we call it the columella, this part right here. So if you were to close that lip right now like that, that patient will probably end up with a nose like this, right? So, can we go to the next one? So with the nasoalveolar molding, what we want to do is to approximate that premaxilla inside of the mouth as much as we can and elongate that columella, so when it's time to do the surgery, we can have a more aesthetic results on the nose. I can stay 20 minutes with this.
It makes it, from a surgeon standpoint, it makes a huge difference. And this baby's crying here. This baby looked exactly like this baby. Exactly like this baby. And then Dr. Holguin, and I'm sad the baby's crying here because this was perfectly lined up. And then you can imagine, from a surgeon's standpoint, trying to stretch this tissue way over here versus just putting two pieces of tissue together here makes a huge difference on scar, on tension, on the wound. And then you can get a nice closure like this. And the kid who ended up with a very significant cleft lip and palate can end up with a great result, you know. So, oh, yeah, let's keep talking.
So my concern, a lot of these babies with the cleft lip and palates, especially when they have a cleft palate, they often will fail the newborn hearing screening. So they're referred to me from the hospitals because of the failed newborn screen. Most of them have some type of middle ear effusion because everything's all connected and linked, and every time they feed, there's milk probably going up into the ears. And so often when they are closing the lip, Dr. Bright, our ENT, will go in there and put some tubes in at the same time so that, one, we're helping them hear better by not having their ears filled with fluid, and two, we can try and combine that so it's one surgery instead of multiple surgeries. So that's where the team part comes in, because no one wants to put their children under anesthesia, and to have to do it more than once is never a great thing. So the coordinating of the team is always good. If he knows he has a patient, he makes sure that he's seeing me before they go in, so that we're trying to get everybody coordinated.
And that's where I come in, because I go ahead and help the patients or the families schedule all these appointments, and I need to make sure that they're seen by every one of these disciplines prior to the patient having surgery. That also involves giving them the education as to why it's important to show up to these appointments, why we need to do them in the order that we're scheduling them for the better outcomes. And then on the little one, I would also, of course, encourage a social worker being involved, because a lot of the times it's a surprise. A lot of the time, of course, we encourage them to be consulted prenatally, but if it is a surprise, we want to be able to make sure that our social worker is able to provide them with all the, not only education, but financial support that we have. And we also have great support groups in our team, and we're able to plug them in immediately. And referring them to ECI right after.
And as you all heard this morning, the first 1,000 days of life are super important nutrition-wise for growth and development later in life. So you can only imagine these little babies that come in, how important it is to make sure they're able to get their appropriate nutrition to grow. Your first year of life, your weight triples. So that first year is very, very important, let alone these first few weeks. So this little guy, it's just making sure, can he even suck and swallow appropriately to be able to get breast milk formula, whatever he is taking in, to be able to get appropriate nutrition to grow. So it's, once again, looking at his weight, looking at his length, measuring his head circumference, looking at his subcutaneous fat source. Is there enough? And if not, going from there, it might be concentrating the formula. So maybe he's able to take, if he's on formula, maybe he's able to take the bottle, but he just can't quite get enough formula. Or breast milk. Maybe he can suck off the breast appropriately, but he's just not getting the appropriate volume. So it might be working with lactation consultant. We have speech on board, and there's tips and things she works with, she does. So that's where the teamwork comes in. I'm just gonna mention, there was a little baby last month, 2 clinics ago, and she's 6 or 7 months old, came up from Juarez, severe bilateral cleft palate and lip. Comes in, and I think they originally, Dr. Holguin saw them the day before in her office and said, you need to come to this clinic. Came the next day, baby severely malnourished. I think it was probably an hour. Speech therapist, Dr. Holkeen, everyone tried to get this child to take a bottle. She wouldn't take anything down. I think it was an hour and she probably took just a couple milliliters. Dr. Holkeen was even taping her lip to see if that would help and just wasn't working. So she eventually was admitted and got a feeding tube placed to help her, and then I don't know follow up. But anyways, that's where the team approach came in. That's what I think of that case in particular.
So, as a speech therapist, with a child coming in with a cleft lip or cleft palate, the first year our primary concern is going to be feeding and some language development. When we see these kids in the hospital, I'm a neonatal therapist at El Paso Children's, they get education. We work with them on trying to find the right bottle that works best for their baby, and each baby is a little bit different. We have different bottles that we can provide for them. The pigeon nipple, there's a Haberman nipple and the Dr. Brown nipple with the valve special feeder. Some of you might be familiar with those. Some work better for some babies. It just depends on each individual child. But we try to provide a lot of education and support for parents so that when they get home, they can feed their baby. Many of these kids can feed. They just need a little extra support. So I'll work with parents on positioning and maybe providing some chin support and just some encouragement. It's going to take a little longer to feed a cleft baby. But we're going to talk about all those things. And then Dr. Holguin does the neonatal nasal alveolar mold, the NAM, so that often helps them feed better once that's in place as well. So that first year, that's kind of what we're going to focus on. And then as this little guy gets older and has his cleft palate repair, well, this was a cleft lip, right?
He had both.
Okay, he's both. So when he gets his palate repair, and he really starts with that language development, we would want to do a comprehensive evaluation around age of 3, assuming that he's talking, check out that articulation, see if there's any nasality or nasal air emissions or things like that that might be going on related to the cleft. And just kind of keep an eye and following. Support the family.
Yeah, so these kids used to standardly get G-tubes, which is just terrible, so it really can be avoided. Most of these kids can feed and they do really, really well. So let's go on to the next. Are you ready for this, Dr. Burke? Bam. So this kid, we get called to the NICU, and they noticed that something was different. And so where are you going to start with your evaluation, Dr. Burke?
Well, this early on, I think we keep hitting the same points over and over with, you just can't separate all the systems that come together in the face. So you have to think about airway and how well is the child breathing, feeding, and are they going to be able to take enough? And what is underlying here, obviously the child has some pretty dramatic asymmetry and a malformed ear, which you just start thinking about the most common thing, which would be hemifacial microsomia, and which would mean that the child has a very small, some very small facial structures on the right-hand side, and that can lead to some feeding, breathing issues, things like this. So the first thing you want to make sure is that those things are under control while you investigate the rest of the problem.
Would you mind, Dr. Burke, expounding on kind of the common findings in hemifacial microsomia?
So common findings in hemifacial microsomia can happen in a spectrum of things, from very, very mild and subtle problems. And once in a while we pick up some mild hemifacial microsomia in the clinic to this more severe. So it tends to affect the ramus and condyle of the mandible, the zygoma, the ear structures, as you can see in this child, and they can also have some pitting, some elongation of the mouth on that affected side, as well as some ear tags are common findings. Of course, ear problems with hearing issues, and the resultant retrognathia, or the mandible being posteriorly placed, can lead to these breathing issues and feeding issues, and then of course learning problems later.
There's also, kind of this systemic issues these babies can have, which actually 30 to 50% have GI issues, GI problems. Some of them can be significant. About 25% can have associated cardiac abnormalities. They also have the tongue doesn't work, or the lingual nerve, which gives sensation to the tongue, doesn't work. So there's a lot going on with these babies, but this is fairly common, and we have a ton of it here in El Paso.
Yes, as the dentition starts developing, we need to evaluate how is the child swallowing, how is the child chewing, making sure that he's not having any issues in those regards. Many times as the dentition starts developing, we start noticing that they have either missing, affected teeth, or extra teeth. So we need to evaluate that too. And as they grow and develop, many times the problem, the asymmetry will start getting worse, and it's related to how the teeth are occluding together. So that's something that we need to pay attention all the time.
I've seen lots and lots of these babies, and it was many of them before I ever knew what hemifacial microsomia was, and now I know what it is, and now I see it all the time. I'll call them and say, there's another baby. They obviously, this baby doesn't have the right ear formed correctly. The canal is closed, so they have oral atresia and microtia, and the ear is low set. They'll not pass a newborn hearing test, so we'll do an auditory brainstem response test, and we can do it through bone conduction and send the sound in through vibration to find out if the inner ear structures are working and intact. And if they are, we can put the baby in a Baja on a soft band. So Baja can be a surgical procedure. Baja is going to make the sound convert into a vibration. So by testing that, if they are having a response through vibration, we can put then the sound through a Baja on a soft band. It looks like a little headband, and then we connect a device on that's going to pick up the sound and convert it. So they're able to hear, because even though many people say one ear is good enough, it's really not. 50% of those kids will have academic issues like speech and language delays, and if you can do something to be preventive, then we want to do that. And the Baja makes a huge difference for a lot of those babies. We put it on and they start to turn, they start to localize, and we can do that early on as soon as we get it approved by insurance. I'm sorry, one more thing. We will also, through ECI, get those children connected to services through the schools. The schools have parent-infant teachers who know how to work with children with hearing loss. Their background is working with children with hearing loss. So they start early on working with them, and then as they turn 3, they start taking over services in the schools. And so getting all of those services in place early on is critical.
So was he able to use the Baja?
You would be able to, except that this one's not my patient.
Yeah, I'm sorry, this one is actually,
I've had several like this who have been able to use it, as long as the soft band. The soft band is elastic, and you just have to tighten it. The trick is being able to get it through the insurance and getting it approved. So.
Talking about insurances, I think that's one of my main roles as well, is working along with the pediatricians and all of the surgeons, and keeping not only the pediatricians but all of the surgeons on the same page, because of course if we need to work on approving one of these big items, and I need to make sure that the communication's in place and that everybody in the team is on the same place. And then especially being so little, we know that he's going to need lots of care basically from everybody. We need to make sure that the family has the support as well as him as he starts growing up. So of course, plugging him in ACI as soon as we can would be the best thing. Transitioning him into the school system and the support programs that they have in school would be one of the main ones. And if they don't require, or if they don't qualify for the support groups in schools, of course, are we able to put him in outpatient therapies, whether it's speech for OT or PT or anything like that would be a big thing.
There's also locally a group called Cheers for Little Ears, and it's specifically for families whose children have atresia, because they have a whole other bunch of surgeries that they are going to have to deal with. Do we open an ear canal? Do we not open an ear canal? Do they do a rib graft to fix the ear? Do they put in, a med-pour type thing once they're older? And a lot of these parents prefer, it's nice to talk to other families, and so having that opportunity to talk to the other families is really good for them as well. And if you have any patients out there, there's also a national organization called earcommunity.org, and they host a national conference and picnic for families, and they've chosen El Paso for this year because we have so many families here. So it's in June.
So as with the others, it's assessing nutritional status, making sure the kiddo is well nourished. Also, looking forward to follow-up, because yes, we're a clinic and this child will come see us, but it might start out monthly and then it might be bi-monthly, every 3 months, every 6 months. And so there are other services in the area that would provide that nutrition follow-up. So everyone's mentioned the ECI. So he's set up the ECI, making sure he is seeing a dietitian through that to make sure he continues to grow well, and just checked on a monthly basis. If there are GI issues, making sure GI is involved on an outpatient basis, and just continues to get adequate nutrition.
Again, as a speech therapist, my concern would be feeding for this little guy. As Dr. Yates mentioned, there's all the cranial nerves are going through. He's got some palsy, he's got some asymmetry. I would be concerned about whether he was able to feed and what his swallow looked like. So I might want to do a swallow, a video fluoroscopy on him just to see that he is feeding okay and swallowing safely. He looks, I'm not sure how old he guy is in this picture, but he looks still pretty young, under the age of 1 for sure. And then the follow-up with ECI and a lot of parent education. I think that's really important, and I think that's an important part of speech therapy is including your parents for your therapy, and doing those little infant scales and just kind of monitoring his language development and overall development that way. And a lot of our therapies overlap a little bit. We're talking about nutrition and speech and hearing and speech and OT and speech kind of overlap. But I would definitely send him to get comprehensive therapy with early childhood.
And I'm just gonna give you a quick overview also of this disorder. So when you see these kids in your office, when you see a kid with microtia on one side, you need to be thinking about this disorder. Because a lot of time, you can have microtia because you have microtia, but a lot of times it is associated with this. So it's called the Omens, and I hate classifications, but this one is helpful. It's called the Omens Classification. So the first thing you look at is the orbit. And so look at the eye. Does the eye look a little different on the right than the left? Yes. It can be smaller, it can be up, it can be down. He has a little, do you see that little thing coming out of there? And that's very common with this syndrome, okay? Not super common with the syndrome, but it is common. So anyway, a referral to an ophthalmologist would probably be a good idea. Usually we just let those hang out there for a while. After the omen, so M, mandible. Look at the mandible. Is the chin point deviated to the right or to the left, whichever side is affected? Is the mouth seeming to just kind of go over there? And if it is, it's probably because he has some hypoplasia of the mandible. Now, you can have all of these things or just some of them. So maybe the mandible's fine, but he has the other ones. So orbit, mandible, ear. Okay, so clearly you can tell something is wrong with the ear. And the ear may just be subtly smaller than the other side. Or, it could be anywhere between that and a regular ear. And then N is omens. So N is nerve. These kids can have those 3 different facial palsies I talked about. They could have a facial nerve palsy. They could have a hypoglossal nerve palsy. So their tongue, you ask them to stick their tongue out, and their nerve to their tongue doesn't work on the right. So the tongue just goes like that. And that's them sticking it out straight. You're like, no, stick it out straight. I bam! You know, I picked up one of these kids. He was 11, had never been diagnosed in our office. And then the other one is the lingual nerve, so they can't feel that side of their tongue. And then S, soft tissue. Omens, soft tissue. So clearly, he doesn't have as much fat on the right as he does on the left, right? And then it's actually Omens plus, and they added the plus because that's when they found out the GI issues these kids can have, the cardiac issues these kids can have. So you see kids like this, and all of a sudden he's having trouble keeping up in PE. Maybe we should get an echo, an EKG. You know, just things to be thinking about. Here's our last case for our panel talk, and this is a really good one. Dr. Burke.
So this young lady, I can see her reflection in the glass back there. I started taking care of her about 6 years ago, and this was the challenge with these cases. When I came to town, my idea was to try to stop the outflow of patients from El Paso, where I had benefited as a resident from that outflow in San Antonio, but I wanted to stop it once I got here. But as I said earlier, I'm a bone surgeon, and I came to find out that there was this fantastic cleft team here, but we were a little bit incomplete, and this case exemplifies that in that we needed somebody like Dr. Yates here to kind of complete our team, and he's done very well. So she came to me, she has this obvious nasal defect, super small premaxilla, which makes it incredibly difficult to get the upper jaw together and make it one bony place, right? Just like the upper jaw should be. And to close all the holes in her palate so she doesn't get liquid in her nose when she tries to drink and air escaping when she tries to speak. And you know, a little girl like this, she has no illusion of looking normal at the end. She just doesn't want to be noticed, right? And so the challenge is to try to get her as complete as possible. And so, you know, she has her upper jaw is back. She had an incomplete jaw, as I said. She's having some speech problems, which these guys will talk about. And her dental challenges are immense. And then the nose is a tough one to fix. And that's something that I wasn't really equipped to try to do for her, but I'm sure you'll talk about that.
Dr. Burke, could you, while you're here, just briefly talk about bone grafting, and then I'll advance the distraction.
Yes, so bone grafting, when I first, you know, I was trained classically, so I would come out and I would take part of the hip, I would crunch it all up into small pieces, I would reflect the soft tissue so that I created a nose side and a palate side and then a lip side. And then you mix that bone that you've taken from the patient and put it in with some bone morphogenic protein, which is in the TGF-beta superfamily, but it signals for bone to, for osteoblasts to make more bone and for some stem cells to convert into osteoblasts. And it's a little off-label use, but I think we're about half the teams now are using it. And then during my practice, I converted to using the bone morphogenic protein has allowed me to stop doing hip grafts, which has decreased the morbidity of the surgery by a lot, as you can imagine, because they never complain about this, they always complain about that. And so you give that some time, and it's a tricky procedure, but it can kind of solve a couple of problems all at once with fluid reflux and air, and also allow the teeth to have a good place to erupt. If teeth erupt into a cleft, they're basically extracted, right? There's not bone there, so they erupt into space. So this allows them to maintain as many teeth as possible, because as Dr. Olkin was saying earlier, they tend to be missing some teeth or have malformed teeth in the area of the cleft, or they have extra teeth which can interrupt their eruption or make them erupt in a funny pattern. And all you have to do, the first thing you know as a dentist, is you let a girl go without a front tooth and you're in trouble, right? You're in trouble. So it doesn't seem important until you say it like that, right?
Okay, I did not meet her when she was an infant, okay? And this was probably one of the most complications we had when we did not have nasal-velar molding therapy. We don't have any pictures of how she looked when she was an infant. We don't have a lot of history on her, but just by seeing her now as a child, we know that probably something went wrong with her premaxilla, or something went wrong with her columella as she was growing up. The other thing that I always pay a lot of attention of at this age, especially at her age, is oral hygiene. Okay, just what Dr. Burke said. A lot of times, surgeons, pediatricians, other healthcare professionals, we don't pay a lot of attention to our teeth until you have a 10-year-old girl that is missing a central. Well, we can prevent this with proper oral hygiene instructions, with proper dental visits. There is many things that surgeons do very well and that they can do very nice, but keeping up with their few teeth that they have, it needs to be a priority. Why? Because no matter how many surgeries they can do, they will not be able to replace the missing teeth or the decayed teeth that you need to extract by the time that they reach their teenage years. And replacing a permanent tooth in the front will cost about $4,000 without bone graft, and it's not covered by insurance, right? So floss the teeth that you want to keep. The ones that you don't want to keep, don't floss them.
Well, I'll tell you too on this, like that kind of it's been oral hygiene's been a challenge. So that affects your surgery. I mean, you can imagine you fix a lip right there, and you just have 700 species of oral bacteria sitting right there, rubbing against your nice lip repair. You get infections, and we did. So
we like to see them on a regular basis. We usually see them every 2 months for oral hygiene instructions, for oral cleanings, for prophylaxis, and especially when they are closer to their surgeries. I will delay a surgery because of oral hygiene. If Dr. Yates, Dr. Burke sends a patient for a dental clearance, I perfectly can say, nope, she doesn't get a surgery. Why? Everything is going to get infected.
With these patients who have an open cleft, again, the concerns are that they're going to end up with fluid into their ears, and so often they'll have conductive hearing losses. And so our job, once again, is just to make sure that we're coordinating services and that, you know, the speech isn't going to get better if she can't hear either. So in addition to having airway concerns and, you know, being nasal because she has a hole and air is escaping through her nose, she can't hear because the ears are filled with fluid, we have to make sure that that's taken care of and addressed as well.
could you expound on why, in particular, cleft kids have ears filled with fluid?
Because all of those sinuses and everything's just connected and linked. And I mean, I had a close friend and she called me panicking because her child couldn't hear and she had a cleft palate and she got tubes put in her ears. And as soon as every time she would feed the baby, milk came out her ears. I mean, it's just all linked. And so if you think about there not being tubes in there, until that palate's closed, we'll see those babies in the office a lot. Dr. Bright sees them pretty frequently because the ears are just draining stuff and it becomes infected, and it requires that team care, you know, to make sure that it's all taken care of.
I may have, so the palate, if it's apart, the muscles that go to the palate, the soft palate, are now abnormally inserted on the bone, okay? And these muscles are the same muscles that surround the end opening of the pharyngotympanic tube that goes.
Yeah, the eustachian tubes back there, everything's all connected
Yeah.
and linked.
So they can't, if they can't effectively use those muscles, they can't open the tube So it's closed, or more closed than usual. And then, yeah, so that's the problem. They end up with, this fluid just being retained, So.
Many of them have multiple sets of tubes, often long-term tubes. And sometimes after the tubes are then gone, then they're scarring. And so they're long-term patients. We see them quite often.
I think this little one, what we would focus on is having a social worker or myself talk to her and see what emotional needs, or if she needs a psychologist or something like this, because obviously her nose and her appearance was definitely important. She wanted to just blend in. So I think the best thing would be, of course, talking to her and identifying an emotional or psychological needs, and of course providing that support. I think that would be my main focus on her, besides coordinating everything.
And then nutrition-wise, sometimes in these older kiddos that come in, this is where we really use the oral nutrition supplements, so your Pediasures, your Ensures, because they may have gone and they've found a way to get food in and to be able to chew and swallow, but they may not, once again, be getting all of the nutrients they need. So that's where those are really great tools to have, where they could just drink a little 8-ounce can and they're already getting maybe a quarter of their calories for the day. So maybe they have 2 of them and that's half their calories right there, so they don't have to struggle as much to get that other half of all of it in just by mouth and normal, regular textured foods.
And as a therapist, there's not a whole lot we can do for speech until the palate's repaired and all those little holes are closed up. But I would be concerned because she may have had hearing loss, that she's delayed and maybe she's missed out on some things because of that, growing up with all those issues. So I would still want to do a complete evaluation on her. We might want to follow her for language, but we might not work on specific articulation until she's had her surgeries and she's had her repair. We can expect that she's probably going to have some velopharyngeal insufficiency and some hyponasality or hypernasality. Those things would be addressed after her surgery.
So she's really interesting, okay? And this is the original, and I don't mean this derogatorily, this is the same disorder where kind of Cyclops came from, okay? This is called holoprosencephaly. And the reason you want these kids seen on a team that sees these kind of things all the time is because these are rare. And this is not normal. So, even for a cleft, this is not normal, okay? To be missing this columellar segment, that doesn't really happen in regular clefts, but that happens in midline disorders. So she's on the very, believe it or not, the very mild end of holoprosencephaly, which the worst end is basically issues, severe cranial issues, and then they can end up with one eye instead of the forehead, and these babies generally come out stillborn. But fortunately, she is of probably above average intelligence. She's really smart. She's a charming little girl, and she had these issues. So these are, for a surgeon, these are very hard issues to deal with. And absent columella is really tough. And she had 2 repairs somewhere else, and unfortunately they didn't work out. So she came to us, and one of my concerns when I saw her the first time was, oh, she has holoprosencephaly. We need to be concerned about her brain, and we need to get a scan. And fortunately, when we got that scan, Dr. Morthy actually identified vascular anomaly that was pretty severe. And the next week, they coiled it off. So, these kind of scans can save these kids' lives in a lot of these situations. Then we took her to surgery. You can see 2013 to 2016. What I'm wanting you to look at is her mid-face, right? This area with the cheekbones. You can see it's progressively not keeping up with her mandibular growth, okay? So, and if you see her teeth, you can see there's a big AP discrepancy, we call it, where the front teeth are way in back of the bottom teeth. So we took her to surgery and we tried to reconstruct the columella. She did not like those scars or the notching, so we used that filtral area. We swung it up, and I was praying a lot this night because you can see that's very white. But there weren't many good options. And fortunately, it ended up doing great. So we got her a columella, and now she had a midline lip closure, which you want to filter them. You want 2 filtral columns on either side of the lip. So we did a procedure for that later, but you kind of have to stage these things. So if you can see here, this is that mid-face hypoplasia. And then Dr. Burke did this portion of the surgery. Do you want to talk about it?
Did you bring a distraction?
Oh yeah, there's a distraction model right up there next to Lily.
So this is my thing. So, so these are, distraction is not newfangled. Lizaroff in the early 1900s was doing this with bicycle parts. What's gotten much more advanced about it is that it's become more elegant. And before they would put these kids in halos and they would pull their face forward. And they would have to wear those things for months, which were horrible. These go in the mouth. You cut the bone in the area indicated there, which is called the Lafort 1 level. And after a few days, you teach the family to turn these at home, and it slowly grows bone in that area, projecting the midface, getting the teeth together. This is an actual skull of another young person who had this done. This is their actual skull made out of on a stereolithic printer. And these are their distractors that, don't worry, we sterilized them afterwards. So I'll pass that around, you guys can check that out. And so after you do this, you over project it by about 20%, so they look a little extra, and it gives them a little room to grow, and plus you expect some relapse. So she did really well with this. Her family was able to do this, and so she didn't have to come see me every day.
Yeah. This is her, kind of before where that maxilla is, and then look how it moves. So the blue is going to move. Bam. Moved. And we plan these virtually. So Dr. Burke gets on with a specialist and wherever they may be, and this is all planned out. The vectors, everything, where to put them, how to bend the plates and whatnot is planned out virtually. And then we get a skull that we pre-bend everything to, and then they're placed in the operating room. This is post-op distraction. Now you can see, so this is pre-op, this is post-op. Now her lips are coming out quite a bit here, but her midface was pretty deficient. That'll normalize over time a little bit. You can see she has a columella, but she still has a severe nasal deformity. But you got, one step at a time. And then her lip, she had this midline lip deformity, which doesn't really, no one wants the midline lip. You want the 2 filtral columns. So the most recent thing we did was something called an Abbey flap, where we tried to get those 2 filtral columns. So we take out that scar, we swing this flap up here, and we keep it attached to the labial artery, which is pretty cool, right? So we keep blood supply going to it for 3 weeks. Now, unfortunately, they can't open their mouth for 3 weeks, right? Because they have to have that blood supply intact. 3 weeks later, we go back and we cut the lip, and so you can see here, we just swing this up, but we leave it attached here, and then we kind of stitch it all together. And this stretches out, so I wasn't too worried about that. So here's after 3 weeks, she's looking pretty beat up, but it's just 3 weeks. Wounds take a while to heal. And her dental hygiene was talking great. Harder to get a toothbrush in with this. And so this is what's providing life to this. But after 3 weeks, blood supply starts coming from the sides. So you can cut this without worrying, which is pretty cool. And so that's what we did. So then this is just a couple weeks later. This is fairly recent, so I don't have any long term. After about 6 months, these scars should look pretty good. And then the plan is to go back and do her rhinoplasty. So anyway, that's her. And then look at her occlusion. Remember how far back it is? It was, and now it's much more forward. So she can actually masticate, chew foods, do all those things. And she's still missing some teeth here, but we have to wait on those two. And that concludes our panel discussion. So I'm going to move right into my talk, I guess.